Welcome. In the previous session on supranuclear disorders of eye movement, we discussed about the disorders of the optokinetic system, the smooth pursuit system, the vestibulo-ocular system, and the ocular fixation system. In this presentation, we will be discussing about the saccadic system and its disorders, the vergence system and its disorders, and also about gaze anomalies. The saccadic system produces a high-speed conjugate eye movements to orient the visual axis from one existing target towards a second new target. Saccades can be voluntary or involuntary. Voluntary saccades are initiated in the premotor cortex of the frontal lobe and reach the ocular motor nuclei through the frontal eye field, basal ganglia, and the superior colliculus. The involuntary saccades are represented by the fast phases of the vestibular and the optokinetic nystagmus and are initiated in the superior colliculus. Velocity of a saccade is proportional to its amplitude. As in vestibulo-ocular system, the cerebellum also plays a role in the saccadic system and fine-tunes the saccadic velocity, accuracy, and maintenance of gaze after the saccade is over, which we will be discussing shortly. We will be discussing the pathways for the horizontal and the vertical saccades separately. For the horizontal saccades, the supranuclear pathways originating from the premotor cortex project to the contralateral pontine paramedian reticular formation, or the PPRF, and PPRF is the primary horizontal saccade generator. The PPRF then innervates its unilateral CN6 nucleus, and as we have seen previously, the CN6 nucleus innervates its ipsilateral lateral rectus muscle and also innervates the medial rectus subnucleus of the contralateral CN3 nucleus to innervate the contralateral medial rectus muscle. So each PPRF generates gaze towards its ipsilateral side and each frontal eye field generates gaze towards its contralateral side. The PPRF contains two types of cells. We have the burst cells, which activate the cranial nerve 6 nucleus, and these cells are in turn activated by the supranuclear pathways. It also contains omnipause cells, which inhibits the burst cells, and the omnipause cells are in turn inhibited by the supranuclear pathways. For the saccadic systems, there is a phenomena called the pulse step integration, which maintains accuracy of a saccade when the eye is moved from one target to another target. So PPRF generates two types of innervation, the pulse innervation and the step innervation. The pulse innervation initiates the saccade, determines its velocity, and overcomes the resistance of the orbital tissues. And the step innervation holds the visual axis steadily on the new object of interest in the new eccentric position once the saccade is over. The pulse innervation determining the velocity and the step innervation determining and maintaining the amplitude should match for the saccade to be accurate. So this is the pulse step neural integration. And the neural integrator for horizontal saccade is the NPH-NVM, the nucleus prepositus hypoglossi medial vestibular nucleus complex in the medulla oblongata. So here we have the NPH-NVM, and the NPH-NVM receives innervation from the PPRF and itself innervates the CN6. Vertical saccades can also be voluntary or involuntary, the voluntary vertical saccades being initiated in premotor cortex and the involuntary vertical saccades being initiated in the superior colliculus. These two pathways converge on the rostral interstitial nucleus of the medial longitudinal fasciculus, and RIMLF is the primary vertical saccade generator and is located in the midbrain. So RIMLF in the vertical saccade pathway is an analog of the PPRF in the horizontal saccade pathway. The center for upward saccades in the RIMLF innervates the third cranial nerve bilaterally and innervates the inferior oblique subnucleus and the superior rectus subnucleus of each CN3 to generate upward gaze. The contralateral third cranial nerve nucleus is supplied through the posterior commissure from the RIMLF, and the center controlling the downward saccades in the RIMLF innervates the third cranial nerve and the fourth cranial nerve ipsilaterally and unilaterally. The pathway from the RI-MLF to the CN4 nucleus is not shown in the diagram, and the neural integrator for vertical saccades is in the interstitial nucleus of Kazan. So the INC is the analog of the NPH-NVM in the horizontal saccade pathway. The RI-MLF contains the excitatory burst neurons for vertical and torsional movements, while INC contains the inhibitory burst neurons for vertical saccades. For assessing volitional saccades, the patient is asked to rapidly alternate fixation between two targets, which are held horizontally and then vertically apart. And for reflexive saccades, the fast phase of the vestibulo-ocular nystagmus and optokinetic nystagmus are assessed. And we attempt to determine the latency, the velocity, the accuracy and the conjugacy of the saccades. Latency implies the delay in initiation of the saccade. Velocity implies the speed of the saccadic movement. Accuracy implies the preciseness of reorientation of the visual axis from the first target to the second target, and conjugacy implies the similarity of the movement of either eye. A hypermetric saccade overshoots the target and is usually pathologic and cerebellar in origin, and a hypometric saccade with one or two small corrective saccades can be normal. In a patient unable to initiate voluntary saccades, the dorsal maneuver will be able to generate eye movement in the direction of the gaze palsy with a CNS lesion, but this does not happen with a peripheral CN6 lesion. This is because the vestibular ocular system, which responds to the dorsal maneuver, bypasses the PPRF to directly innervate the 6th cranial nerve nucleus. Saccadic dysfunctions can be hypometric, which occurs with peripheral lesions, and in hypometric saccades when the patient attempts to reorient the visual axis from the first to the second target, there is a lag in the movement of the eye and the visual axis lags the second target. Midbrain lesions affect vertical saccades while pontine lesions affect horizontal saccades. Hypermetric saccades occur with cerebellar lesions, and in a hypermetric saccade when the patient attempts to initiate a saccade from the first target to the second target, the saccadic movement overshoots the target and the visual axis also overshoots the target. Slow saccades with normal amplitudes and increased latency occur in lesions of the cerebral and basal ganglia, such as progressive supranuclear palsy, Huntington disease, Wilson's disease and Whipple's disease. Gaze-evoked nystagmus occur with leaky integrators, the integrators being the NPH-NVM for the horizontal saccades, the INC for the vertical saccades, and also the cerebellum. And with a leaky integrator, there is an inability to maintain eye position after the saccade is complete. So when the patient attempts a saccade from the first target to the second target and attempts to sustain the gaze towards the second target, the eyes drift back away from the second target, followed by a corrective saccade in the direction of the second target. In myasthenia gravis, there may be faster than normal saccades which stop short of the second target. So myasthenia gravis has high speed saccades which are hypometric. Congenital ocular motor apraxia is a type of dysfunction of the saccadic system. Please see a video of congenital ocular motor apraxia on the internet. Apraxia is an inability to generate a voluntary movement which can be generated by other means, thus indicating a lack of paralysis. Ocular motor apraxia results in prolonged latency and or failure to initiate saccades, but once initiated, saccades are of normal velocity but hypometric. Both volitional and reflexive saccades are affected, and on OK drum testing, the eye gets locked up in the direction of the drum rotation after the slow phase of the optokinetic reflex occurs. In congenital ocular motor apraxia, the patient uses head thrusts in the direction of and past the second target. The head moves past the new target to overcome the response of the vestibulo-ocular system to the initiated head thrust, so as to maintain fixation to the new target with an eccentric position of the eyes in the orbit. This is followed by a slower head movement in the opposite direction to bring the eyes into primary position in the orbit while maintaining fixation to the second target. What is happening in congenital ocular motor apraxia is that when the patient is attempting to shift gaze from the first target to the second target, the patient cannot initiate a saccade and takes the help of a head thrust in the direction of the second target. In response to this head thrust, the vestibulo-ocular system, which is normal, initiates a movement of the eye in the opposite direction. In order to overcome this VOR, the head thrust overshoots the second target in order to maintain alignment of the visual axis towards the second target. So, after the initial movement, the eye is eccentrically positioned within the orbit, and this is followed by a second slow movement of the head in the opposite direction towards the first target so as to realign the head in the direction of the second target, so that the eye is now oriented in the primary position within the orbit. If a child with congenital ocular motor apraxia is held and spun around by the examiner, the eyes move in the direction of the spin. That is because the direction of rotation the child perceives is opposite to the direction of rotation the examiner perceives. But no corrective saccades occur in the opposite direction, the reflexive saccade produced by the vestibulo-ocular and the optokinetic system. Newborns affected with congenital ocular motor apraxia may be misdiagnosed as blind, as head thrusts are not generated by newborns, and with age into adulthood, thrusts decrease in intensity and are replaced with blinks. There is an idiopathic type of congenital ocular motor apraxia called the Cogan type, which affects only horizontal saccades. But when this congenital ocular motor apraxia occurs with other neurodegenerative diseases, both horizontal and vertical saccades are affected. Acquired ocular motor apraxia results from bilateral damage to the supranuclear gaze pathways in frontal and parietal lobes, and it usually occurs as a result of cardiac arrest or cardiac surgery. And both horizontal and vertical voluntary saccades and pursuits are affected. Vestibular reflexive saccades may be intact, and the patient blinks and turns the head to reorient fixation, and it may occur as a part of Balint syndrome, in which we find optic ataxia and simultagnosia, which we have discussed in an earlier session. Acquired saccadic palsy occurs due to damage to birth cells in PPRF and can also occur following cardiac surgery. So in contrast to acquired ocular motor apraxia, which occurs with lesions in the frontal and the parietal lobe, acquired saccadic palsy occurs with lesions in the PPRF in the pons, and thus both volitional and reflexive saccades are affected, sparing all other eye movements. Familial horizontal gaze palsy with scoliosis is an autosomal recessive disorder with horizontal gaze palsy, both volitional and reflexive. Vergence and vertical saccades are intact, and progressive scoliosis develops later in the patient. Now coming to the vergence system. Vergence system provides for slow movements of the two eyes in opposite direction. So the eye movements are not conjugate in the vergence system, and vergence movements can be either involuntary or voluntary. Among involuntary vergence movements, we have tonic, fusional and accommodative. Tonic vergence aligns the eyes straight ahead when awake. Without tonic innervation, the eyes would be divergent due to the orbital anatomy. Fusional vergence occurs in response to images of an object being projected on non-corresponding retinal areas in the two eyes. And accommodative vergence occurs in response to blurring of the image of a near object on the retina, which results in accommodation, which in turn causes convergence as part of the near reflex triad. And the pathways for the vergence movements are indefined but involve multiple regions in the cerebral cortex in the frontal, parietal, temporal and occipital, and they converge on the mesencephalic reticular formation, which in turn innervate the medial rectus subnuclei of cranial nerve 3. Assessment of the vergence system involves assessment for the near point of convergence, fusional vergence and accommodative convergence. Near point of convergence is assessed by bringing an accommodative target slowly towards the subject, and the furthest point from the nose at which the eyes start to diverge is said to be the near point of convergence. Fusional convergence is measured with gradually increasing diopters of base out presence, And fusional divergence is measured with gradually increasing diopters of basin prisms till diplopia occurs. And accommodative convergence is measured either by lens gradient method or heterophoria method. In the lens gradient method, we do a prism bar alternate cover testing at distance fixation without and with a -2D lens placed in front of each eye, and the difference in the deviations is divided by 2. And in heterophoria method, the deviation at near and the deviation at distance are both measured, and 1/3 of the difference between these two deviations is added to the interpupillary distance. Coming to dysfunctions of the vergence systems, most supranuclear disorders, as we have seen, do not cause diplopia, but vergence dysfunction do result in diplopia. Convergence insufficiency is characterized by diminished fusional convergence resulting in exotropia at near, and there is eye strain, headache, blurring and diplopia during near work. In most situations, it is not associated with other neurological findings, but it can be so with closed head trauma, Parkinsonism, progressive supranuclear palsy and dorsal midbrain syndrome. Treatment includes convergence exercise, monocular occlusion, prisms and surgery. Accommodative esotropia results from a high accommodative convergence by accommodation ratio, which we will be discussing when we cover strabismus. Spasm of near reflex are intermittent episodes of increased convergence, accommodation and meiosis. So all the three components of the near reflex occur together intermittently, and there is esotropia at distance, but the esotropia is more at near. It is almost always benign if there are no other neurological signs, but like convergence insufficiency, it may also be associated with neurological disorders like dorsal midbrain syndrome, thalamic hemorrhage, Wernicke's encephalopathy, Arnold-Chiari malformation, stroke and multiple sclerosis, and it can be psychogenic with other somatic symptoms. In divergence insufficiency, we get esotropia more at distance than at near. So in divergence insufficiency, the esotropia is more at distance, and in convergence spasm, the esotropia is more at near. Error function is intact in divergence insufficiency with normal abduction, saccadic velocity and amplitude. Like other vergence disorders, it is benign if not associated with other neurological deficits, and it may occur in the elderly as part of sagging eye syndrome, which we will discuss when covering strabismus. It may also be found with raised and lowered intracranial pressure, midbrain tumor, Arnold-Chiari malformation, head trauma, thyroid-related ophthalmopathy and cerebellar degeneration. And treatment includes monocular occlusion, prisms and surgery. Central disruption of fusion may occur with midbrain injury and other lesions in the midbrain, and there is intractable diplopia not responding to either prism or surgery. Intermittent fusion and stereopsis is however present. Coming to gaze abnormalities, and gaze abnormalities can be gaze preference due to lesions in the frontal eye field, or gaze palsies due to lesions in the midbrain and pons, and tonic deviations. So gaze preference arises from unilateral stroke in the frontal eye field, and there is an inability to produce volitional gaze to the contralesional side. However, this can be overcome by Dolcet maneuver by utilizing the vestibular ocular system. So if there is a lesion in the frontal eye field of the right side, gaze towards the left side is disrupted. Gaze preference is a temporary phenomena and disappears in days to weeks after the onset of the stroke in the frontal eye field. And usually the eyes are deviated towards the ipsilesional side, but may also be in the primary position. Wrong way eyes occur with thalamic stroke, and in wrong way eyes there is deviation of the eyes contralesionally. Gaze palsy can be horizontal or vertical, and horizontal gaze palsy usually results from pontine lesions, and this results in inability to move the eyes ipsilesionally. So pontine lesions which involve the PPRF and the CN6 of the right side results in right gaze palsy. And if the lesion is in the CN6 nucleus, the gaze palsy cannot be overcome with a Dolcet maneuver. If the lesion is in the PPRF, the resulting gaze palsy may be overcome with the Dolcet maneuver. If the lesion is in the rostral portion of the PPRF, Dolcet maneuver will be able to overcome the gaze palsy, but if the lesion is in the caudal portion of the PPRF, Dolcet maneuver will be able to overcome the gaze palsy. But if the lesion is in the caudal portion of the PPRF, then doll's head maneuver will not be able to overcome the gaze palsy. And since horizontal gaze palsy results from pontine lesions, horizontal gaze palsy may be associated with ipsilateral facial nerve paralysis and or ipsilateral first order Horner syndrome. With a bilateral pontine lesion, horizontal gaze in either direction is disrupted, but vertical gaze in both the upward and in the downward direction are preserved. So a large pontine lesion produces a locked-in syndrome in which there is quadriplegia and loss of all voluntary movement except the vertical eye movements and lid elevation, which are spared and which differentiate the locked-in syndrome from a comatose state. Partial PPRF lesions produce ill-sustained gaze resulting in gaze-evoked nystagmus with the fast phase towards the side of the lesion. And Mebius syndrome is a congenital anomaly in which there is aplasia of the 6 nerve nuclei along with facial palsy. Vertical gaze palsies occur as selective limitation of upgaze and or downgaze, and it occurs due to lesions in the midbrain. Posterior commissure or pretectal lesions result in limitation of the upgaze more than the limitation of the downgaze. In dorsal midbrain syndrome, also known as pretectal or Parinot syndrome, there is a limitation of conjugate upgaze with a convergence retraction nystagmus. In convergence retraction nystagmus with attempted upgaze, co-contraction of the extraocular muscle results in retraction of both the eyes, and this is best detected with O'Kane drum rotating downwards, which generates saccades in the upward direction. There may also be lid retraction in primary gaze called Collier's sign, convergence spasm or insufficiency, skew deviation, light near deviation, and square wave jerks. And it can occur with multiple sclerosis, stroke in the basilar artery distribution, pineal tumors, hydrocephalus, or Whipple's disease. Progressive supranuclear palsy, also known as Steele-Olszewski-Richardson syndrome, starts with vertical gaze palsy, and the downgaze is involved earlier than upgaze, followed by horizontal gaze palsies also. So ultimately, gaze in all the directions are involved. In PSP, we also find postural instability, unexplained falls, and dementia. Upgaze palsy may also occur in Wilson's disease and kernicterus, but we must remember that predominantly downgaze palsy are usually not clinically found and diagnosed because of the associated loss of consciousness from damage to reticular activating system. Tonic deviations differ from gaze palsy in that with a gaze palsy, when the patient attempts to generate a gaze, the eyes do not move in that direction, but in tonic deviation, the eyes are deviated without any attempt by the patient. Seizures of the frontal eye field causes overactivity of this region of the brain, resulting in contralateral deviation of the eyes during the seizure. So if you have a seizure of the right frontal eye field, the eyes will be deviated towards the left side, followed by deviation of the eye ipsilaterally as part of the post-ictal Todd's paralysis state. Tonic downward deviation occurs with dorsal midbrain syndrome in children and with intraventricular hemorrhage in premature infants. It may also occur with metabolic hypoxic encephalopathy, massive subarachnoid hemorrhage, and acute obstructive hydrocephalus. In tonic downward deviation, doll's head maneuver cannot move the eyes out of their tonic position, and if there is a lid retraction along with tonic downward deviation, it is called the setting sun sign. And if it occurs with or without bilateral esotropia, raised ICP is a major concern. So in tonic downward deviation, the eyes are deviated downwards and the lids may be elevated, and this is called the setting sun sign. Tonic upward deviation, also called oculogyric crisis, occurs as a reaction to certain drugs such as haloperidol, fluphenazine, and metoclopramide. Tonic upward deviation may also occur with Wilson's disease, and tonic upward deviation responds promptly to anticholinergic drugs such as prochlorperazine. Transient tonic upgaze and downgaze may occur in healthy newborns, but doll's head maneuvers can move the eyes out of their tonic position in these situations. As we have seen, the cerebellum is intimately involved in supranuclear control of eye movement. Saccadic dysmetria can occur with lesions in the dorsal vermis and vestigial nucleus. Lesions of the flocculus may cause impaired fixation, with gaze-evoked downbeat or rebound nystagmus and saccadic intrusions, or may also cause impaired smooth pursuit, including inability to cancel the VOR. Lesions of nodulus may be associated with impaired VOR and optokinetic systems. With a posterior fossa tumor, we may have an acute comitant esotropia not correctable with spectacle, prism or surgery. So an acute comitant esotropia is an indication for urgent neuroimaging. Arnold-Chiari malformation may be associated with a large number of supranuclear disorders including gaze-evoked nystagmus, downbeat nystagmus, Q deviation and divergence insufficiency esotropia because of the involvement of the cerebellum. Now coming to ocular motor system development in infancy, VOR is the most well-developed system at birth and is well developed by the end of the first week. Saccades and vergences are detected after the first month, and the horizontal saccades develops before the vertical saccades. Smooth pursuit to large objects are present at birth, but full maturation may occur as late as late teens. Transient ocular motility abnormalities are found in newborns, and up to 1/3 of newborns may show ocular misalignment. But as a rule of thumb, esotropia beyond 3 months and exotropia beyond 4 months is abnormal. Newborns may also show transient skew deviations, transient tonic vertical deviations as we have just discussed, and transient lid retraction. Thank you for listening.